So the topic is ultrasound detection of pneumothoraces in trauma, essentially. The article that I was given was by Nagrasheth and Stanley, and it was published in the American Journal of Surgery, I believe. Yeah, I missed the surgery part there. There's the volume and all the specifics if you want to look it up, or you can ask us afterwards. And essentially what the topic was, it was to compare the detection of ultrasound in a trauma situation and compare the rate of detection of a pneumothorax when you take it to the gold standard, which is CT scan. But also what sort of was very interesting, and that's sort of the crux of their study, was how sort of inefficient the chest x-ray is in detecting a pneumothorax by most people. Like, there's a lot of disputable results gained from there, and they're advocating the usage of an ultrasound as sort of a primary method of detection of any pneumothorax that may be significant clinically to be used instead of sort of the normal ATLS standard that we currently have, which is a chest x-ray. Why they did this was I just explained to you, because their goal was to show that a ultrasound is far superior than the chest x-ray when compared to the reference, which is a gold standard, the CT scan. And obviously a pneumothorax after trauma can be a life-threatening injury, thus requiring a very quick and accurate diagnosis and intervention. And obviously in that situation, our go-to is a clinical diagnosis, and if we're in doubt, we treat accordingly. But if we have some time or you just want to double check, then obviously any sort of imaging modality is quite helpful. So as we mentioned, the chest x-ray is still part of the ATLS protocol, but obviously, as I mentioned earlier, and we all know, radiological confirmation should not delay ideally any clinical treatment that is warranted given the situation. But what they're trying to show is that in a trauma situation, time is of the essence, as we know. And sending a patient or getting a portable, getting a portable chest x-ray, on average, they showed in one study from China, from Zhang et al., was that it took about 19.9 minutes to do the chest x-ray portable, plus or minus 10.3 minutes, via the ultrasound, which just takes about 2.5 minutes. So you have it right there. And you can just plop on the probe and see the results. And several studies have shown a chest x-ray sensitivity for detecting a pneumothorax is between 36 and 75%, although the specificity is 100%. So, but the sensitivity is the issue, and you can see there's a wide range there with the chest x-ray. And they sort of took that result from a number of studies, larger studies than they did in terms of numbers recruited. And as I mentioned, there's a high rate of completely missing a pneumothorax on chest x-ray. So the purpose was that there is a significant difference in the sensitivity of detecting a pneumothorax between an ultrasound and a chest x-ray, and that it can be part of the FAST protocol that we use in a trauma situation, and that essentially the ultrasound is far superior. I want to keep hammering that across. So the study itself was a prospective single-blinded study with convenience sampling, and we'll touch upon what convenience sampling is, because I wasn't sure what it was, so just for the benefit of everybody else. At a level 1 trauma center in the States, which compared a thoracic ultrasound to the chest x-ray and then eventually the CT scan. The chest x-rays were read by a radiologist who was blinded to the results of the ultrasound that was done in the trauma situation. So they did not know what the clinician saw when they did the ultrasound, and they were blinded to that result, and they read the chest x-rays and then eventually the CT scan. Then both of these interpretations were compared to the CT scan results, which is the gold standard. And this is an issue we'll talk about when we sort of break down the study, is the convenience sampling. They didn't go elaborate too much on this in terms of what they entitled convenience sampling. All they mentioned was that it was based on researcher availability. So convenience sampling, they didn't necessarily take all the patients that initially came in sequence, because they did the study over 2 years, a 24-month period of time. They didn't go into details of who was selected, why they were selected essentially, and what this research availability was. Was it one radiologist that was specialized in reading this, or was it only a couple of them who could come at a certain time? They didn't really go into any of that, so we don't know exactly why it was based solely on research availability. And that's something we can break down as we go through the study. But convenience sampling essentially is any sort of study where patients are selected in part or in whole at the convenience of the researcher, and they just take them as they pretty much choose. There's no sort of taking of the samples as they come. So it's not sort of entirely random. And so that, and please correct me if I'm wrong, Shelley, because obviously you're an expert in this area. So at any time, if I'm saying something wrong, just please let us know. I don't want to propagate false information today. So there was inclusion and exclusion criteria. The inclusion criteria obviously was the patient had to be a trauma patient, and they must have received eventually all 3 image modalities. So a chest X-ray, a CT scan, and an ultrasound. Obviously to compare the two, and the gold standard is the reference, which is the CT scan, and the indexes are this chest X-ray and the ultrasound. So they had to receive all 3. They were excluded for 3 main reasons. If they were transferred with a chest tube, they were excluded. A needle decompression, if they received one, obviously, during the resuscitation. And if they were found to have any subcutaneous emphysema of their chest or their neck. They didn't go into too much detail as to why they chose this as an exclusion criteria, but reading on this topic, I gathered that, you know, when you insert a chest tube in and you get local reaction, obviously the pneumothorax is going to decrease in size, it's going to be harder to detect. You may be biased by palpating subcutaneous emphysema, or it may obscure your findings on the ultrasound. So I guess these are the sort of reasons that I looked up would be possible for their exclusion. They didn't really go into details as to why they chose these 3 as an exclusion criteria, but that's what they listed. So eventually what happened is, this is the breakdown. They took 125 patients, and they all received a chest ultrasound, as I mentioned, over the 24-month period. The other imaging modalities that they used was the CT scan and obviously the chest X-ray. Of those 125 patients, only 79 received all 3 imaging modalities because they met the inclusion criteria. But 46 were excluded from this study. And they didn't, and we'll talk about as to perhaps why they were, because they didn't really detail that either. But essentially, out of the 125 patients that did receive a chest ultrasound, only 79 received all the chest X-ray, as well as eventually the comparison criteria, which was the the CT scan. So 79 is the number we're working with. So then I went into JAMA to sort of break this down with respect to how to do a proper analysis of a diagnostic test and see if it's worthy of incorporating to our study here at London Health Sciences. Into our practice here at London Health Sciences. And so we broke it down. So they obviously have criteria that one should go through to see if a study's results are valid. And so the first criteria is, was there an independent blind comparison with a reference standard? So I have to admit, yes, there was. The CT scan was the gold standard, and the radiologist reading it was blinded from the ultrasound or chest X-ray results when they read the CT scan. So that's sort of noble in that they were able to achieve that. Are the results of the study valid? So did the sample include an appropriate spectrum of patients to whom the diagnostic test will be applied to in clinical practice? Potentially, because the fact that they didn't really go into details of the patient, in terms of the patient comparison, they didn't really state as to clinically what their findings were on clinical exam when they came into the trauma bay and why they were eventually selected. It's sort of really vague on that. And it's hard to discern if they were biased when they put their ultrasound probe on. Were they clinically desatting? Did they have absent breath sounds? That sort of stuff was not really even alluded to when they mentioned the detailing of the study breakdown. And as I mentioned, the convenient sampling, and then eventually only 125 trauma patients. I know Shelley brought up this very good point. They chose 125 trauma patients, but out of, what was this percentage of? How many trauma patients did actually come in to the ER from which the 125 were chosen? We don't know because they didn't mention that. And then it was extrapolated to sort of compare to how much trauma patients we get here in a year or 2 year span period. And I wasn't able to find out exactly how many trauma patients we get here. If someone can add to that, Dr. Pringle, if you would know on the stats on that, please feel free to mention. But far as I'm concerned, I don't know the exact number of how much trauma patients we see here over a period of a year. But they didn't mention how much trauma patients in total they saw there either. But eventually they took 125. And that obviously would sort of weaken or strengthen the results depending on how much of a proportion that was. But we don't exactly know the proportion. So did the test results being evaluated influence the decision to perform the reference standard? So as I mentioned, there were 125 patients that were ultrasounded, and only 79 received all the 3 imaging modalities. Why were 46 excluded? Was there a bias when the first ultrasound was done to decide who gets the chest X-ray and then eventually who gets, obviously, the CT scan? What was influencing this decision? Again, we do not know for sure. So there is suspicion of a partial verification bias there, and so that is of concern as well. Were the methods of performing the test described in sufficient detail? Yes, and I'll get into that. So who did the scanning and how? So they chose 6 surgical residents, and they trained them in a course of a day to detect pneumothoraxes via ultrasound. And they essentially did only 10 ultrasound examinations, and apparently were experts by 10 ultrasound scans, which I sort of find hard to believe. I've never done an ultrasound to find a pneumothorax, so I can't comment on that, but it just, having done just the basics, it takes so many scans to pick things up, so that's up for grabs there as well. The tools they used were the Siemens Sonoline, and I'm not going to regurgitate that for you because you can see the specifics of the machinery there. Obviously the 10.5 megahertz was much more superior, and they even commented on that. The probe placed was in the typical position at the mid-clavicular line, bilaterally between ribs 2 and 4 in a supine trauma patient. And if that was hard to find, they would also go to the anterior axillary line, again ribs 2 to 6, to detect the pneumo. And the positive finding was discerned by an absence of lung sliding and comet tail artifacts, which Danny will comment on because he knows his stuff. I just, for completion's sake, wanted to put up the picture there. As we can see, the chest wall and the pleural lining there, and it's not a video, so we can't appreciate the lung sliding, but typically you'd expect the 2 interfaces there to sort of slide past each other if there was not a pneumothorax. And then the comet tail artifact, just to visualize how it looks like, and that's right there. I don't know if it's clear in the light here, but. So what were the results? When we wanted to figure out the results to see how powerful the diagnostic imaging was, unfortunately, we can't calculate the pretest probability here, as I mentioned earlier, because we don't know really how they presented. Was there any findings of tracheal deviation, absent breath sounds, low O2 sats, etc., that increased the suspicion amongst the ultrasonographers to do the ultrasound in the first place, to rule out a pneumo? So we don't know the pretest probability. Results. I'm just going to break it down here. So they took a chest X-ray and the ultrasound and then compared it to the CT results of the 79 patients. The ultrasound was a positive diagnosis. When the ultrasound was positive, it was 100% accurate with the CT scan. And same with the chest X-ray. If the ultrasound was negative, there was a 6.6 error rate when compared to the CT scan, because the CT scan picked up apparently 4-5 pneumothoraxes that the ultrasound did not. But then they commented on these. One was read as an occult posterior pneumothorax versus a bleb, so the radiologist was not sure on CT either. 2 were occult pneumothoraxes in the apex, and one was one was positive for inferior small loculated pneumothorax in a patient with a prior history of thoracic trauma. And again, they commented on all these being clinically insignificant, not requiring thoracostomy. And when the chest X-ray was negative, there was a almost 21% error rate when compared to the CT scan, a rate that was 38.15 times greater than the ultrasound. So just to review, because it had been a while since I looked at this stuff myself, but a sensitivity of any test is a proportion of patients with a disorder that have a positive test. Thus, it is a good test used to rule out a disorder, and specificity is the opposite. It's a proportion of patients without a disorder who have a negative test, and thus it is a good tool used to rule in a disorder. And then, just for completion's sake, we're going to do a positive predictive value and a negative predictive value. So a positive predictive value is a proportion of people with a positive test that have the condition, whereas NPV is the opposite. And here's a table. I just broke it down just to illustrate how we came across the calculations in terms of sensitivity and specificity for just the ultrasound. I didn't bother doing it for the chest X-ray. And just breaking it down, the specificity is 100%. The sensitivity is 0.818, with the positive predictive value of the ultrasound being 100%, and negative predictive value being almost 93%. So essentially the sensitivity of the chest x-ray was 0.318 versus, as I mentioned, the ultrasound, which was 0.818. The specificity for both was 100%. No statistically significant difference between a CT chest and ultrasound for pneumothorax detection. So that's surprising. As I mentioned, the positive predictive value was 1 for both. The difference lied in the NPV, where the chest x-ray had 79% and the ultrasound had 94%. So that's quite significant. And then we did the likelihood ratio, and that is used to indicate how much a given test, how much a given diagnostic test result will raise or lower the pretest possibility or probability, of a target disorder. Again, we don't know the pretest probability, but we wanted to see how effective the ultrasound is in helping us to make the diagnosis of a pneumothorax. And so the value we got, and that's how we calculated it, was 0. And that means, in terms of likelihood ratios, and we'll break it down in a quick graph there, a chart there, that essentially you can be 100% sure that there will be a pneumothorax if you find one on ultrasound. No. Okay. Well, close to it. So, essentially, and I think Shelley will correct me, but essentially the ultrasound is a very powerful tool as a diagnostic imaging modality that can help us to discern if the patient does have a pneumo or not, to help with our clinical suspicion. A likelihood ratio expresses the odds that a positive or negative ultrasound test result will be expected in a patient with or without a pneumothorax, and it provides a direct estimate of how much a test result will change the odds of having a disease. And so if it's positive, it tells you how much the odds of the disease increase when a test is positive. And our value obtained for this was 0. For the likelihood ratio, in terms of negative likelihood ratio, it was 0.182. And both these point towards it being a very effective tool. And that's just by the range of interpretations we have for likelihood ratios. And the smaller the number, the more better the test is. The more larger the number, the more better the test is. And there's an intermediate range there that I mentioned in terms of values, in terms of helping to change a pre-test to post-test probability. Will the results here that we found in the study help me in caring for my patients? In terms of reproducibility, I think I do agree with the study's authors that the ultrasound machine is an amazing tool. It's really portable. It's right there available for us in the ER. It's very easy to interpret if you know obviously what you're doing, as opposed to the chest x-ray where there's lots of debate. Even amongst experienced radiologists, you can have different findings on chest x-ray, and it's always hard to pick up the small pneumos or obscurements, and the transporting of the patient if they're unstable to the CT scanner and all that kind of logistical issues that we deal with in the trauma bay. The ultrasound really is a very amazing tool, and I think that reproducing the results of the study generally should not be hard to do, because we do have access to an ultrasound machine here, and we do have very well-trained physicians in ultrasound technology, and they can obviously be a resource to us to help bring us up to speed in terms of knowing how to do an ultrasound to rule out pneumothorax. Are the results applicable to my patients? Well, I haven't had to do this, but just extrapolating, I think of course it is. We do see obviously a lot of trauma here, and we do have all the resources that we generally want to have, depending on the time of day. But an ultrasound is very easy to do, and it's right there. And we do have similar inclusion-exclusion criteria for our patients that we see here, and I can't see as to why we wouldn't be able to apply the results here to the patients that we see in the trauma bay. And I think people are already doing this all the time, those who are trained in being able to use the ultrasound probe for this disease when it presents. Will the results change my management? I think so. I'm going to make a concerted effort to learn how to use the ultrasound machine in terms of for ruling in and out pneumothoraxes. I haven't been trained in that, but it was something in the back of my mind. But after having read this study, I definitely want to pursue that more aggressively, at least personally. And I'm sure that people who read the study or talk to other colleagues, as I have found this to be a pretty amazing tool to find out if the patient has a pneumothorax. Will the patients be better off? I think so. Again, indeed, just by being able to do the ultrasound right there and then not having to transport them to the CT scan or waiting for a portable chest X-ray, all that kind of stuff. If we're sort of in the middle, we're doubting whether or not clinically the patient has it, putting the probe on and seeing if it needs to be treated is a very good tool, I think. The references that I mentioned were the actual study itself and then the JAMA articles, and obviously I really harassed Shelley on this because I must admit it's been a while since medical school I broke down a journal like this, and so I really did need her help, so I did appreciate all her feedback on this topic. I wouldn't be here without her help. So I think that's pretty much it. If anybody wants to comment before Danny comes up, please feel free to do so.
I may have missed it, but did you mention were all the chest x-rays supine AP films, or were there, did they say?
They didn't mention, but we're presuming that it's a supine patient. It's a supine trauma patient, the inclusion criteria, so they would have done a portable on the supine patient. They didn't actually explicitly mention if it was a PA, that kind of stuff. They didn't mention that. We're assuming that it is supine.
I mean, from a clinical point of view, I think it would be important to know, what kind of chest X-ray it was, because I mean, there's no question that supine portable chest X-rays are poor for detecting small pneumothoraces, but I mean, clinically, we really don't care about that so much, because in almost all cases, they're going to go on to get an upright chest X-ray or a CT, in which case you're not going to miss it. So it would help to know, just from a practical point of view, that's a terrible sensitivity for the chest X-rays, but I'd like to know if those were all supines or if there's some of them were upright chests or not. Yeah,
they didn't mention that. Yes, Dr.
And similar question to Trevor's, do they mention at all the volume of these things, the size of them, their location? Because, missed on chest X-ray, I question the clinical significance of a very small apical pneumo missed on chest X-ray that you see on CT. It may be clinically irrelevant anyway.
No, they didn't detail that either.
I think that would be the most important point, like you were saying, that how useful this would be, and I would argue I don't think it's very useful. Okay. I mean, if you see a trauma and somebody's arresting in front of you, or they're very sick, or they're hypotensive, and they're respiratory stress, well, almost all of us are going to there's a few things we can do to help them. We'll give them some fluid, some blood, slam in bilateral chest tubes, and intubate them, but that's about all we can do. But to see a pneumothorax, I mean, having done a million CT chests, we find occult pneumothoraces on CT by the bucketful, and some of them, it's really, really, really impressive how big they are that you can't see on a chest X-ray because they're collapsed totally posteriorly. But there's been some good studies that have come out that said, we don't need to do anything about those. Even ones people going for positive pressure ventilation, they're going POR. Fair number of studies now that show that you don't need to do anything about them. So, I mean, I was talking to, this actually came up in trauma M&M rounds last week, and Shelley, maybe you'll be interested, but we talked about maybe even doing a study, because if they're that large on a CT and then they become clinically relevant, then you've got to think that the chest X-ray also really means nothing. If you see a small one on chest X-ray, and my practice in the last year or two has been, even if I see them on chest X-ray, I go by clinical. Are they in respiratory distress? Are they desatting? Are they really uncomfortable with it? Yes, then put a chest tube in. If not, just send them to the floor, even though we see it on chest X-ray, and they go home. We've all put in chest tubes, and you see how uncomfortable they are, and that big, huge hose going in. It's just not very much fun. If I was a patient, I certainly wouldn't want one. I said, listen, they're supposed to reabsorb it, 2, 3, 4% a day. I wouldn't want a chest tube. So I talked to Daryl and Neil about that. Maybe we should do a study that even if you see them on chest X-ray, if they're in no clinical distress, let's do nothing. Because it makes sense to me that chest X-ray is really irrelevant. And I can't tell you how many times that, you're in a noisy trauma room, you come in, residents are super keen, the general surgeon, they yell, decreased air entry on the right, chest up, chest up. I said, no, settle down, there'll be no chest tubes here. And they say, no, Dr. Prick, come over, listen. And I go over and I listen. Yes, I agree, there's decreased air entry. And the chest X-ray is normal. The CT is normal. So once again, probably maybe doing things to patients when we don't need to, which clearly can cause some harm. So, we know the clinical exam isn't that great. We know the chest X-ray is not that great, but is it relevant? I don't know.
And I think that's the bottom line with this paper, is that we don't know. because as you mentioned, Ahmed, we don't know what the actual denominator of the study is. They said they tried to enroll 125 patients. Due to partial verification bias, they only ended up enrolling 79 patients. We don't know why those other 46 patients didn't get the gold standard. So I think you'd have to question that. 125 patients over a 2-year study period, I don't quite know how accurate that sample would be. And then my only other point would be, we can get on this later because I don't think we've had a good ClinEpi session this year that details what likelihood ratios are, but do you think it's possible to have a likelihood ratio for a positive test that's actually 0?
No, not in real life.
So actually what happens is, when you actually go through and do a 2x2 contingency tables, stats software programs don't accept a 0 as an answer because it's not actually possible to have any kind of a specificity or sensitivity that's actually 100%. The upper limit of your confidence interval certainly can reach 100%, but the actual point estimate can never actually be that. So what that program actually does is put in like a very, very small integer, so like a 0.01. So if you go back through the actual calculations and redo it, your positive likelihood ratio actually is huge. It's about 409. So what would that do if you had a pre-test probability of, let's just say, based on maybe prevalence if you thought it was accurate, and let's just say your gestalt of, you have a lady that comes in, your pre-test probability is 15%. You have a positive likelihood ratio because she's had an ultrasound as an index test and she had a positive finding on that. Do you think your suspicion for her having a pneumothorax would go up or down?
It's going up.
Absolutely. And that's from the mnemonic of Dave Sakic, who we all know, the spin and snout, that sort of stuff that you touched on earlier. But I would caution you and I would put forth to you that I wouldn't change any management based on this paper. And I think Derek's right. I think that the question's still out on this and maybe we should pick up the ball and actually redo this study properly.
Right.